Welcome all on the behalf of Indian Society of Critical Care Medicine. I welcome you all for this evening session. Today we are going to discuss about the monoclonal antibody, its current position and experience about it. Our esteemed panelists are Dr. Yatin Mehta, who is the past president of Indian Society of Critical Care Medicine, as well as he is my chairman as well, and he is chairman of anesthesia and critical care at the Medanta, the Medicity. Dr. Kapil Zirpe, our past president and head of the Department of Neurocritical Care at Ruby Hall Clinic, Pune. Professor Curino, he is professor and head of the Department of Anesthesia and Intensive Care at San Filippo Neri and member of the board of Federation European des Medical Bruxelles. He is president of World Society of Total Intravenous Anesthesia as well. He has got large experience on this cocktail, and he was one of the primary author on this, so he'll be sharing his experience. Dr. Subramanian Swaminathan, he is American board certified internal medicine and infectious disease specialist. He is senior consultant infectious disease at Glenengel Global Health City. Dr. Om Srivastav, he is consultant infectious disease and HIV at HIV medicine at Jaslok Hospital and Sir H.M. Reliance Hospital, Kasturba Hospital at Mumbai. Dr. Jose Chacko, he is consultant at Narayana Healthcare, Bangalore. Dr. Prashant Nasa, he is head of critical care medicine at NMC Specialty Hospital, Al Nahda, Dubai. And today's moderator is young, energetic Dr. Rajesh Chand Mishra, who is president-elect of ISCCM, and he is consultant intensivist and internist based at Ahmedabad. So without wasting much time, I'll hand over to Dr. Mishra.
Thank you, Dr. Deepak sir, for the kind introduction. And before we go to the main thing, just a few introduction why we are planning this monoclonal antibody cocktail in COVID. We all know that COVID infection has created a havoc in last 1.5 years. We also know that vaccination was probably one of the ways to prevent and contain the disease, though not in every case. We also know that we do not have any definitive treatment to treat the COVID infection once the disease goes beyond its limit. There is another thought coming in COVID that it is HIV in fast progression. That's what the thought is coming from few of the ID specialist people. Based on this thought, there are one more proposed therapy to contain the replication of virus that's called monoclonal antibody. The problem with the monoclonal antibody has been that if it has been used as a single drug, it has not been successful. So to contain the virus replication as well as to prevent the resistance and as well as to be effective in different variants, the cocktail has been proposed. There are two different cocktails available which has been tried with the success in preventing replication as well as progression of the disease. But there are definitive times when this can be used. So today's discussion and talk will be what are the monoclonal antibody cocktail, how it works, where we can use, where we should not use. But before that, we have Professor Curino from Italy, who has done extensive work right from the inception of this concept in molecule. He has been a principal investigator in all the trial of the cocktails, and he wanted to share his experience. So very precisely, I'm going to give, before we start discussion, I'm going to give Dr. Curino 10 minutes for discussion, and then we will take up from there our discussion. So Dr. Curino, over to you. Can you, Ninad, allow sir to share his screen?
Yes, sir. Yes.
Dr. Curino, can you share his screen? Shall I do that thing?
Just a second. In the same time, I make a good evening to Yatin, my friend. Nice to see you. It's okay for you? Is a presentation mode?
Okay. Yeah, perfect.
Okay.
So go ahead.
Okay. I can go? Okay. First of all, I would like
No, sir, move to presentation mode. It is not yet presentation mode.
Oh, sorry.
Yeah. Just go to presentation.
Just a second. It's okay now?
Yeah.
Yes, please. This is perfect.
Fine. Okay. Okay. Thank you so much for this kind invitation, and I am very glad to see so many friends and to discuss with my proposal that is a new approach that in Europe we are discussing, and not only Europe. As you know, the confrontation has now taken one of the tones of a dialogue between fans of two opposition and historical irreconcilable teams. Among the doctors, there are on the one hand the supporter of vaccination, some of whom scoff at those who defend the importance of early treatment. Other, those who claiming their role in the territory with respect to hospitals, sometimes left understand that the home care for COVID-19 can in some way be an alternative to immunization. Not the case, and there should be not need to emphasize that the opposition does not make, but perhaps it may be useful to pause and reflect coldly on this issue. And what I would like to do. SARS-CoV-2 has two characteristics which combine contribute to misleading. Fortunately, if we have a relatively low lethality rate, so much so that for the vast majority of infected, it resolves in a low, not severe form of flu, but from its, on the other hand, especially in the new Delta variant that is prevalent now, it is highly contagious. So the most serious is to underestimate the infection. Today, that thanks the mass vaccination, I need to move because I can read. Can you please take off the video screen here? Okay, no? Qui non riesco a leggere. Just a second. Okay, now it's okay. The vaccine cannot, no, say, and that in the other. The most serious is to underestimate the infection. Today, that thanks to the mass vaccination of the elderly, the average of the infected has fallen below 30. And we can say that well over 99% of infected recover from COVID-19. Yet, even ignoring the medium and long-term consequences of the infection, that long COVID that is still too little talked about, even for young people and adolescents returning from mild forms of the disease. The percentage in this case can be misleading. In fact, given the high contagiousness of the Delta variant of SARS-CoV-2 in a population that still includes millions and millions of susceptible individuals, including millions of 40, 50 and over, that 1% can translate into a number far from negligible number of victims. And if the virus were allowed to circulate freely, in addition to the tip of the iceberg, that it will not make it, there would be tens of thousands of patients who would remain marked for months by the disease and would first flock to emergency rooms, hospitals, and intensive care units, subtracting resources for the treatment of other conditions and indirectly causing an additional burden of disease and death. The vaccine cannot completely prevent. This is clear to everyone now. The risk of transmission, but it reduces it as well as greatly limits the possibility of getting sick, especially with severe forms. The data that these days show the enormous discrepancy of vaccinated and unvaccinated patients in intensive care units. In various countries around the world say so. Treatment is fine, but there is no doubt that if a disease can be prevented, this approach is to preferred. A respiratory virus with a high such rotation, such as the Delta variant of SARS-CoV-2, if not contained in the same way with non-pharmacological measure or with vaccines spread so rapidly that any treatment, it will be impossible. To think of an alternative, it would be necessary to have antiviral drugs available to everyone, easy to administer at the first symptoms, and with proven efficacy in suppressing the infection. The indication of a usefulness of the treatment must come from randomized and controlled trials conducted with methods rigorous enough to earn publication in the main international journals. And when these works were carried out, like in the past, they repeatedly reject, for example, hydroxychloroquine, ivermectin, vitamins, or supplements to support COVID-19 patients in the first phase of the disease. On the other hand, the administration of heparin is fundamental and is confirmed, especially in bedridden patients at risk, and dexamethasone, but only with overt pneumonia, while in the larger stage is contraindicated because it can aggravate the situation by reducing the patient's defenses. Then there are monoclonal antibodies in cocktails and in monotherapy, which are still looking for their place in treatment protocols, since they will probably find much more easily if and when they manage to be authorized products to administered intramuscularly or subcutaneously, so that they can be used without risk at home. This would avoid the need to resort to a protected facility for infusion into a vein, as required by those currently on the market. New perspective could also come from budesonide, which, according to a study published in The Lancet, would seem to shorten, at least based on the patient's subject assessment, the duration of the disease. Unfortunately, it's too early, however, to prescribe it to patients with COVID-19. Confirmation of more significant effects of risk hospitalization death is required before authorization by regulatory agency. On the hospital care front, in the meantime, it is possible that other treatments, in addition to steroid and to anti-interleukin-6, may prove useful. The World Health Organization has just kicked off a new trial as part of an initiative called Solidarity Plus, and we take part in this organization. Thousands of researchers in over 600 hospitals in 52 countries will try to use free drugs already available against COVID-19. The first one is anti-malarial artesunate. The second one is the antineoplastic imatinib, and the third one is a monoclonal antibody infliximab. So we can say that the anti-SARS-CoV-2 monoclonal antibody...
Dr. Quirino, 2 minutes to summarize. 2 minutes to summarize. Yeah.
Sorry.
Yeah. Go ahead, please. Go ahead.
I go? Okay. Anti-SARS-CoV-2 monoclonal antibodies that target the SARS-CoV-2 spike protein and block virus entry into cell have been evaluated for treatment of COVID-19. Today, the Food and Drug Administration and all the European regulatory agency has used an emergency use authorization for the following anti-SARS-CoV-2 monoclonal antibodies and combination that these are used in Italy. Bamlanivimab alone, Benlanivimab plus Etesivimab, and Casirivimab plus Indevimab. Data are emerging. I have no time to show you our data, but I will leave the slide so you can use. Data are emerging on the monoclonal antibodies, including the preliminary data from a phase 3 trial of Casirivimab plus Indevimab and on the vitro susceptibility of SARS-CoV-2 variants to anti-SARS-CoV-2 monoclonal antibodies. After reviewing the available data, the COVID-19 treatment guidelines panel. The panel is playing a very important role in this moment around the world, as an update is a recommendation on the use of anti-SARS-CoV-2 monoclonal antibodies in outpatients, not in the hospital. I want to underline this, with the mild to moderate COVID-19 who are at high risk of disease progression. In addition, the panel notes that because of an increasing number of reports of variants that are resistant to Bamlanivimab alone, this product will no longer be distributed in the US government. And also us, we don't use by alone. In other words, the COVID.
But Dr. Kurino, can we take on discussion further? So just so shall we go on to discussion now?
Sorry?
Now we want to go to discussion.
Okay. Okay.
Yeah.
I stop. Okay.
Yeah. Thank you.
No problem.
Thank you. Thank you for your. I mean, it was a really nice introduction for the topic and a good summary. So can you stop sharing, Dr. Kurino, so everybody can come on the set?
Yes, you can share with all. The slide is in your end, and you can do as you want. Okay.
Yeah. Thank you. So with this background, before we really go to the monoclonal and monoclonal antibody cocktail, a little bit about what is monoclonal and polyclonal antibody. Anybody? I mean, I don't want to ask direct. Prashant, yeah, Dr. Subra, you want to comment about what really monoclonal antibody is and what is the polyclonal antibody? Because audience would like to know that what we are going to discuss about and what is the background behind it and how it, just a general principle in 30 seconds, how it works, if it can.
So, just so everybody knows, the concept of monoclonal antibody is not new. We've been doing this for rabies in the past. So if somebody has a very severe injury from a dog, we give them both the rabies vaccine and the monoclonal antibody because we want to prevent severe disease. The first indication for the monoclonal antibody is something similar. If you are infected by COVID, you're preventing severe disease. So the idea behind monoclonal antibody is that it's targeted therapy. Instead of just lobbing an atom bomb, instead of that, you're doing a surgical strike where you target only the virus and nothing else. The advantage is that it affixes only to a specific part of the virus, which is a spike protein. And I'm going to stick to only the combination that's available in India, which fixes it in 2 different places. Polyclonal antibodies are basically antibodies which work in different areas. And obviously, not all of them have protective benefit. The anti-spike antibodies are the ones which have the protective benefit. And that's why the development of monoclonal antibodies is specifically target a spike antibody. And because it only targets a spike antibody, there should ideally be no collateral damage because there is no human target for that particular antibody. That's the philosophy. And that's the philosophy in every monoclonal antibody. So as an idea, it's not new, but the way it has been done is obviously very revolutionary, and it has clear indications and endpoints. Polyclonal antibody, because it's a mix of things and you don't know how much of it is going to be actually effective and actually preventive, it's going to be a problem. It's more like a dirty product. This is more like a refined product.
Okay, Dr. Om Srivastava, very quickly to a question, and then I come to Dr. Mehta sir because he has to go, so I'll come after that. But this is a relevant question, and because related to little bit about the COVID-19 strain variant, because this is very important to decide about the infectivity, resistance, upcoming problem, their severity. So the COVID variant, the different terminology, and particularly COVID variant of concern, what it means to us.
Yeah. Okay. So thank you, Rajesh. Very interesting question. For those of us who we've not met, good evening again, everybody. So the WHO defines some loosely termed, paradigms, which are COVID variant of interest and variant of concern. When you say variant of interest, it is a variant that is infecting a community by any more than about 2 to 30%. When you say there is a variant of concern, it is affecting over 30% of people at any one given point in time. Now, there are several ways to approach this. There are epidemiological models, but we are not going to go into that. Variant of concern is where one particular strain of the COVID virus is causing disease which is clinically significant in enough people who will require to go to emergency departments of a hospital, or will need to be hospitalized or go on to ICUs and ventilators. So variant of concern, if you look at the data that comes out of, say Peru right now is sitting on a time bomb. Peru, the data, the variant of concern from Peru is the biggest variant right now. But there are multiple other variants from the UK, from the US, from New Zealand also. For a country that was under lockdown, they locked down because they had one patient. At one time, they came into lockdown because they had one patient. Now they have got about 20 patients. So it has automatically become a variant of concern. So variants of interest and variants of concerns are going to be terms which will be applied to those strains which are likely to cause enough burden where patients will seek medical attention or be hospitalized or be, unfortunately succumb. So these are terminologies also to reflect that there are changing patterns. We are not yet at the end of COVID, and these changing patterns need to be evaluated with a lot of caution, In the US, the kind of numbers that the US is seeing with children that mimics, conditions like Kawasaki syndrome is not to be scoffed at. They are huge numbers, but they are all recovering with some organ damage. That's where we are. We are probably going to be seeing, if we end up having the third wave, we're probably going to be seeing something like that, where there will be end organ damage, but not mortality in ICUs and ventilators. This is my feeling. Rajesh, back to you.
Thank you. Mehta sir, very quickly, the monoclonal antibody, they have been proposed that they work by working as an anti-spike protein. And then one monoclonal antibody tried in OPD basis, in mild to moderate cases, they failed. So what is the reason behind failing one monoclonal antibody, and what is the concept behind combining the monoclonal antibody as a cocktail? So what is the reason behind and why we are giving as a cocktail?
That's a good question and very relevant one, Rajesh. Thank you very much. And nice to hear Corino and Om and Subra before me. Okay, now coming to your main question. See, now Bamlanivir, which has not been recommended as a single therapy, works at one particular site on the spike protein. And it has been found that the incidence of the Delta variant or the variants of concern was increasing, particularly against the mutations. It is not effective. And that study had to be stopped in that particular drug, and that's why FDA has withdrawn the permission. On the other hand, a combination therapy, like what we are talking about, casirivimab, imdevimab, now that works at two different sites on the spike protein. So the chances of mutation happening at those specific points is less, and therefore the efficacy will be increased. And several studies have shown the combination therapy to be quite efficacious, particularly in OPD patients with mild to moderate disease who are not on oxygen and not hospitalized, obviously. It was a significant mortality difference and hospital admissions difference. Also, if you look at the second category, I'll just quickly summarize the two, three things where it can be a benefit. One is outpatients. who are mild to moderate disease, not oxygen dependent. You give one shot and most of them will not require hospitalization. So it will not progress to severe disease. Second group, with a recovery trial, with a good large number of patients, it was shown that hospitalized patients also, it can be of benefit, particularly more so in patients who are the antibody levels were very low or not absent, negative, seronegative patients, but significantly again benefit of progression to severity and mortality benefit. The difference was not so much when you took seropositive patients. So that was not really the good idea. But in hospitalized patients also it can be benefited. And the third group of patients where it is of benefit is high risk exposure to them, the post-exposure prophylaxis. And a large study has come out from US where they found that post-exposure prophylaxis significantly less morbidity, mortality, hospital admissions in patients, families who were given with high exposure to a COVID positive patients. So it does make more sense. The combination works at two sides rather than one side. And for mutations also it will work again, hopefully.
Prashant, very quickly, who are the group of patients whom you will give monoclonal antibody cocktail?
Thank you, Dr. Rajesh, and inviting me over here. I have heard a lot of things from the senior colleagues. So the patient to add on, we have missed a very important monoclonal antibody which has been approved. I think UAE was the first country which approved for that. It was Strovimab, which is a single monoclonal antibody, unlike the other cocktails which are available. So it's a very much important because this is the only monoclonal antibody which has been found effective for all other variants, including the Delta variant. So we should be discussing about that monoclonal antibody. Maybe later on, I think you will be taking that. But yes, the subgroup of the patients where we should consider, especially in mild to moderate disease, are the one who are having a risk of progression. So these are the patients, obesity, BMI more than 30, patient with chronic kidney disease, patient with chronic respiratory disease like COPD or moderate to severe asthma, patient with age above 65. So these are the patients who we know now have a high risk of clinical progression, and the patients who are expected to not mount adequate immune response, as Dr. Yatin sir said, the post-exposure prophylaxis. So these are the patients which we are expecting not to get an adequate immune response. They have some either immunodeficiencies or they have been proven a B-cell defective pathway. So these are the patients one should consider. Besides that, there are off-label use which are being done for pregnant patients, again with risk factors, even with BMI of 25 to 30, like what we are doing for now with a greater experience of more than 13,000 patients in UAE alone. So we have started offering this for combination of two risk factors, a BMI of 25 to 30 and hypertension. So this is being, because of a very low side effect, adverse effect has been reported. So we have extended use it to even lower BMI. So these are the subgroup of patients where we should consider.
I will come to this specific, but very important question to Dr. Kapil, to you. Whom you will not give monoclonal antibody cocktail? Who are the patient of COVID whom you will not?
I always believe that what COVID taught us is the timing selection of the patient. These two things are true for everything. Whichever the treatment part you take it from the COVID, your timing and selection. And let me tell you this need to emphasis to the everyone across the country that you need to know that which patient not to, like younger individuals, they are healthy ones, they are mild symptomatic. Why they are not indication? There's no need to get panicky. So I will say that those are not fitting in the risk factors are the candidates which please don't offer them. You can monitor them. You are still 1 week or 10 days to observe. And it should not be the panicky treatment. And that's what I observe left and right monoclonal antibodies in even full dose monoclonal antibodies, even on the NIV and ventilated patients. It is so those patients who are admitted on NIV or high flow or even on a ventilator, please don't consider in a severe COVID pneumonia. It's not the right treatment unless and until it was properly discussed with your ID guys and everyone regarding the risk and benefit. Because of the recovery trial, that extension is adding into the confusion, that is not adding into the help. I have seen that the patient is on NIV, that's why they are giving the full dose of cocktail. I think that needs to be discussed at length and avoid such indications of not to offer them this particular treatment.
Dr. Joseph, so suppose in a, like you are in a setup where you have to take a decision to give a cocktail of the monoclonal antibody in a patient. So what will be your checklist, like based on the things which we discussed, whom you will give, whom you will not give, how will you make a checklist of it? Very quickly to summarize what Deepak and everybody has said about giving monoclonal antibody to any patient.
Yeah, Rajesh. So as we have heard from others, the treatment as we know today, based on the evidence that we have today, is directed mostly in patients with mild to moderately severe disease and within the first 7 days of illness. And this is most likely to benefit in patients who do not have a natural antibody response. And the risk group we've already discussed, which include patients who are older than 60, 65 years, those who have underlying disease like pre-existing lung disease, including COPD, those with end-stage renal disease, obesity, pregnancy, and immunosuppressed otherwise. So these are some of the indications for use. And as I mentioned, the most important thing is to ensure that they have mild to moderate disease and they are within the first 7 days. That's what most of the antibody cocktails, including casirivimab, imdivimab combination, has been used within the first 7 days. And as Kapil mentioned, there is some additional use perhaps in patients who are hospitalized as well. Again, they should be within the first 7 days. If they are seronegative to begin with, they may benefit. There was a difference of 5% in terms of the 28-day survival in the recovery study. So perhaps that's another reason to consider using it in patients who are early enough and hospitalized during the course of the disease. So just broadly speaking, these are some of the indications wherein you would possibly consider monoclonal antibody therapy.
Okay, and Dr. Kurino, a very specific question to you. A patient who has been given one dose of vaccine, one dose of COVID vaccine, any of the vaccine has been given, and that patient if get COVID infection, what will be the position of monoclonal antibody cocktail? When will you give or not give?
No, we don't give. We apply very strictly the rules of the panel. And we know that we must be very far from the vaccination period. So if the patient is vaccinated, there is a conflict between anti-monoclonal therapy and the vaccination. So we don't give. I would like to summarize that I see some question that the only test that we do for propose our patients for anti-monoclonal therapy in hospital is the immunodeficiencies, as NASA say before. This is perfect, and also with the patients with a very low anticorpal rate. This is just the few exception where we use anti-monoclonal therapy in the hospital. Otherwise, this therapy is created just to reduce the recovery in the hospital. This is the main purpose. We must always think about this.
So, so what Dr. Kurino says, if you have been taken even one dose of vaccine, you have to look for the antibody level. Most probably he is no, but if antibody is well below the level, then one probably you can consider. Dr. Subra, you want to add something to this comment?
I think when we look at the spectrum of use of the monoclonal antibody today, it's still evolving. And I think there are going to be changes in the approval. As of right now, I think I would rather stick to comments basically about the approved indication, which is for prevention of progression to severe illness. But let's not forget that there's a clear mortality benefit in patients who have severe COVID if they're seronegative, and also in prevention of transmission. And that could be something which is effective, useful for patients who are significantly immunosuppressed. And that's where this concept of vaccine comes in. Somebody has one dose of the vaccine. See, if you look at the way the studies are done, they talk about people who have not completed the vaccine adequately. So any patient within 15 days of the second dose could still be considered as a candidate because they're still very vulnerable. And the data suggests that the risk for bad outcomes is significantly higher. So the other option is doing antibody test, but not everybody has antibody tests to come through very, very quickly. Yes, if you have an antibody test, which you can do and then proceed from there, that's fine. Otherwise, I would say look at whether 15 days have elapsed from the second dose. If that's not happened, then you should consider them as unvaccinated/under-vaccinated.
What about poor responder, Dr. Om? What about the poor responder to vaccine?
Rajesh, you're asking whether such patients should be given monoclonal antibodies? Is
Yeah. There are three categories of the patient whom we are discussing. One is the patient who are having high risk, mild to moderate, high risk patient who can get, everybody is clear. Second category, 1 dose given or 2 dose given, not to give there, you have to look for the antibody level. But there are a patient who has been given 2 doses and still antibody response is not appropriate. Do we need to give monoclonal antibody to them or not?
That's a very good question. I think that this would be evaluated based on the risk that this patient is going to be having for getting complications. 1, and 2 is at what stage have you met the patient? If the patient has come to you beyond the 7th day, then I think that you've got to be careful about.
Just I will stop here. Just everybody is mentioning 7 days, but the original trial has very precisely says 96 hours. This is they're talking about.
Yes.
So we are extending the window up to 7 days, or shall we cut off?
Dr. Rajesh, for post-exposure prophylaxis, it should be given as early as possible.
Yeah.
But the EUA authorization by US FDA is up to 10 days, up to first 10 days.
Okay. That's fine.
So,
but
look,
in that 10 days, there is a rider that patient should not have progressed to oxygen requirement. There should not be lung involvement and all those factors. Yeah.
Exactly. The criteria remains the same. No oxygen requirement, no hospital, and mild to moderate.
Exactly the point that I was just about going to. If your patient has gone into a situation where you think that it's gone beyond a certain stage, it's the 7-day period is not arbitrary. It comes out of a number of evidences and also clinical experience. That kind of patient should be evaluated very strictly clinically, whether or not giving a monoclonal antibody will be of any benefit to him. There's one quick point I'd like to make, more out of my my own work as an immunologist. We need to define immunodeficiency more clearly. When we say immunodeficiency, we need to quantify it. In my own practice, I routinely do lymphocyte enumeration. That means your patient CD4 counts, CD8 counts, your B cell, your T cell, your natural killer cell, your immunoglobulins and complements. Because a T cell, when you give a monoclonal antibody and you get a secondary bacterial infection, of course, I'm sure you're going to come to that, Rajesh, but secondary bacterial infections after you've given a monoclonal antibody will be responsive depending upon how much is your patient's T cell population, because if you have wiped out the entire T cell population with any monoclonal antibody that you have given, then your patient is at a much higher risk of succumbing to a bacterial infection. I'm sure this is something that you will discuss later. I'd like to speak about it later, but I'm going to stop at this point here.
Okay. So in a patient who is a poor responder, shall we treat those patients as category 1 who are high risk to progress to severe disease and look for the antibody level? If it's not appropriate, then we need to give them the full dose of monoclonal antibody cocktail. Everybody agrees to that? Any difference of opinion on that?
In one word, yes. In one word, the answer.
Yeah, that's fine. Because this was one gray area where a lot of confusion used to come in last couple of days. So I thought I'll just clear this issue. So just little about what is the dose and how to give. Prashant, quickly, if you can summarize, if you can.
Okay, so now there are only 2, antibody combinations which are available. Bamlanivimab has already been removed from the indication from US FDA. Bamlanivimab and Indimacimab. Sorry for the mispronunciation of the name.
That's fine. That's
definitely. We should not be talking anymore about them. The combinations which are available are Regencov, that's Cizumab and Imidimab, and the Strovimab. So the current use is 600 milligram of both the indications, which has been found effective, almost nearly effective as of 1200 milligram. So the US FDA clearly says 600 milligram of both the cocktail is good. For Strovimab, it's 500 milligram, single shot. Again, the process is the same way. You have to give the injection over 30 minutes, monitor the patient for 1 hour. The most common immediate reaction can be hypersensitivity reaction. Delayed side effects are less than 1%, and mostly it's a post of nausea, vomiting, and rarely pruritic and rash. That's all.
Dr. Deepak, sorry, I missed it. If you have selected to somebody to give monoclonal antibody, the observation side effect, and there are very specific group of patients which I was discussing, the non-responder, particularly if somebody is non-responder and is healthcare worker, what will be the monoclonal antibody protocol for those group of patients? So there are two questions for you. The first one, how will you monitor the downstream of monoclonal antibody?
Get it.
How will you monitor if somebody has been given a monoclonal antibody, what side effect they are going to monitor? So it's like downstream side effect. And the second group, there is one second. Sir, yes, sir. Yeah, please go ahead, please.
So it is just hypersensitivity reaction. We have to monitor for the hypersensitivity reaction. That's it. And
what is the preference route we are giving, IV or subcutaneous?
So both the routes are there. IV could be given and subcutaneous, but majority of the places are giving IV, I think.
Preferred route is IV. Yes, we can.
IV. Why, Prashant? So
subcutaneous has been found only with one trial. So it's not been, even the US FDA say, if only you cannot give an IV, then only you should try for a subcutaneous route. Strovimab is only IV. The resin COVID combination is only for IV and subcutaneous, but it's only a single trial where they found subcutaneous can be effective.
And also the subcutaneous dose, you need to use 10 mils, which is not easy to administer subcutaneous.
That's another point.
So preferably should be given IV.
Yeah.
I was just asking one more very specific question, particularly this is pertaining to healthcare worker. If you are a poor responder to vaccine and you have been exposed to COVID infection and you have been given post-exposure prophylaxis, so what protocol should be followed in this patient for the post-exposure prophylaxis of antibody cocktail? I'll start from Kapil because this is very specific group of patient. And would you like to extend the therapy or would you like to just usual precaution and one dose? How will you do that in this class of patients?
I haven't understood your question. Sorry.
Sir. So there are a group of patients. Suppose you are a healthcare worker, you are a poor responder to COVID vaccine. Your response is not. So you have been exposed to COVID infection and it was decided, you are a high risk, decided to give monoclonal antibody cocktail. So what will be what protocol we are going to follow in this group of patients who are at high risk and has the risk of repeated exposure?
I think I would follow which are the current guidelines, as every one of us know that there is a limited data is available. So I would not like to do it trial and error with my healthcare workers. I will go through the whichever the guidelines are available. If it fits into the that particular indication, I will definitely go ahead. If it is not fitting in that, I would like to monitor him closely. That's what I will prefer to do. No specific separate protocol for the healthcare worker.
Dr. Quirino, do you have any specific protocol for this group of patients? You're muted. You're muted.
Yes, one moment. Yes, all our patients are put in a national register. Otherwise, you see how many variants we are discussing. We try to make an homogenic population. Otherwise, all the data are not good for scientific purpose, okay? And we give the same dosage to all the patients. And because there are no differences in the publication, in the result about the two combination, you can do the same, you can choose what you prefer of the two combination. What it is really important that you give the same amount of the drugs to all your patients. Another things that it's really important, you must follow all the panel indication. We know that the medicine is a gray zone. If we are expert in this field and if we watch patients, probably we decide in a different way to approach to him. And this is not possible when you are going to have a strictly study to decide which beta combination you can give and which dosage. So we put also the indication and all the laboratory data in this register. So anyone can have an idea of the situation. And just for this, we have a lot of patients in all the hospitals, from all the hospitals in Italy. And also another important issue is to say which is the date of vaccination, because another important indication is to know exactly when the guide was vaccinated, how many dosage, and how far was from the therapy, the vaccination, at least not less than 90 days. This is the recommendation of the panel. Okay.
Thank you. Thank you. Dr. Subra, very quickly, just if you, can you just little, if you have, if you can just elaborate about a little bit about the pharmacokinetics and dynamics of the monoclonal combination that will help us in addressing the question which I've asked you, because it's a very specific question and very few cases they are there, how to handle those cases. So I'll tell them.
Yeah. So basically, it's given as a 100 ml saline infusion. Obviously, the most important thing which people should know is that it should not be agitated at all, because it will break up. It has to be gently mixed. This is a mistake a lot of people do during the process. It has to be gently tilted, not even shaken. But it's only 100 ml of saline. So actually, in terms of volume, it's very, very small. The good news is it really does not have any metabolism or post-infusion kinetics as such. It does not do anything in your liver, does not do anything in your kidney. So the great news is you do not need to adjust it for renal function or liver function. Anybody over 40 kilos of age, the dose is pretty much standardized. And even in pretty morbidly obese patients where it has been used, you don't need a higher dose. Even at the 1200 milligram dose, it works very well. So great news. It's a one-stop shop provided the patient is at least 12 years and 40 kilos. And as long as they meet criteria, you don't have to change the dose. There's really, it spontaneously decays in the body, and there's nothing that needs to be done.
Okay. Dr. Jose, sir, would you like to address my question?
Can you repeat that question, please, Rajesh?
Yeah. So I have a question, because very specific question I'm asking. Otherwise, I will answer now. The question is that suppose you are a healthcare worker,
yes,
and you are a poor responder to the vaccine,
yes,
and you have been exposed. You need, that's what's called a post-exposure prophylaxis of the dose has to be given.
yes.
So what?
Could you use monoclonal antibody or not?
And you will no. You will give monoclonal antibody, but what regime we are going to follow in this particular set of patients? Because the half-life of this drug is around 28 days, both of the combination.
Okay.
And then it is said that once you have given this medicine, one just given monoclonal antibody for 90 days, you cannot give another vaccine for 90 days.
Okay.
So the safety, this patient who is a poor responder, he has been given monoclonal antibody, and he is at risk of repeated exposure. We are definitely going to follow all the precautions of the distancing, mask, hand wash, everything for the healthcare worker. But even somebody is at risk and he gets exposed, he gets repeatedly exposed. It's not a hypothetical question, it's an ideal question, because these are things which have been addressed. So how we are going to address this condition? Prashant is smiling, probably he would like to answer.
You have already answered, you have already said half-life is 28 days. So for repeated exposure, you can get repeated after 4 weeks. That's what US FDA approves.
So the only reason I am asking this question is because this vaccine can be repeated. Sorry, this monoclonal antibody can be repeated in a patient who has at risk of repeated exposure after 4 weeks, but the dose further goes down, and dose is half of that. And that can be given another 2 doses until like you are definitely getting away of it. This is one point which I wanted to bring in attention, that suppose, but because the important thing is that once you have given this monoclonal antibody for 90 days, we cannot give vaccine. That's what the thing is. That's one point very important. So going a little bit away from the monoclonal antibody, I will ask the experience, Dr. Om, how many patients you have used in your practice, and what has been the response so far?
So at one of the hospitals, which is probably the biggest hospital in North Mumbai, the Seven Hills Hospital, which is part of the Reliance group of hospitals, we've probably used it in excess of about 75, maybe 80, maybe even more, but not less than that. We've used it in about 75 patients. In the initial part, we didn't probably time it very well. We probably poorly selected because of, because it's not one person. There is an entire intensive care unit, and there are some anxieties there as well. But once we got a protocol and a streamline, after that, our results have been excellent. We'll be publishing that. Our results have been very good. Out of the 75, if you were to count maybe 65 or a little bit more, I think we've got good results in over 90-95% patients. So it definitely works. But like everything else in medicine, you've got to time it correctly. You've got to pick your patient correctly. You've got to give it at the right time. You've got to give it at the right time. So
now here is a catch, Dr. Om. There are two contrasts. There are patients who are having high risk, and there are patients who are having no risk. What Dr. Kapil was saying, that there will be young patient without any risk of progression. So, and in younger patient also, we have seen sudden mortality. So how we are going to find out that group of patients, are particularly younger lot, who do not have any apparent risk, which is not visible risk to progress the disease, but they can suddenly worsen. So how you are going to time monoclonal antibody in that group of patients?
It's a good question, Rajesh. But that is why we are clinicians, okay? We don't treat papers, we don't treat numbers, we don't treat X-rays and CT scans. We treat patients. So if you're at the bedside and you're spending even a few minutes, 10 to 15 minutes, you will know with the experience that comes after maybe 10 years of practice, you will know this patient has a bad feeling. You got a bad feeling about this patient. And if you back that, you're going to be able to warn the other people in the ICU or the ward that, look, please keep a close eye on this patient, transfer him to ICU. I've got a feeling that this patient might crash, and observe that. But like I said, these are subjective things. They vary from patient to patient. I can recount dozens of instances where I have fought with the administration not to discharge patients because I thought that there was something seriously wrong, even though the papers and numbers look good. And it turns out to be right most of the times if you're looking at that part, authentically. But I also see the point that you're making, Rajesh, that not always possible in busy hospitals. When you are assessing 40 patients a day in a clinical meeting, then some things are going to fall in the crevices of the time constraint or resource constraint, or simply the fact that the person on the spot is maybe a little bit inexperienced or maybe a little bit anxious. So if you have in your own mind the definition of high risk that meets the criteria of high risk in your own mind, I would say never ignore that. Never ignore that. That is, I'm sitting in the presence of very senior people like Dr. Deepak Goyal. I would like to hear what they have to say, but this is my own impression, and this is how I'd like to practice myself.
Kapil, your thought on your experience and thought on monoclonal antibody in summary, and your experience both.
Yeah. We have used quite with a stringent criteria, and I was always blamed in my hospital for making it more stringent. I used some 30+ cases, and all did well, and few of them were rewarding. It was just giving you the whatever the results you are expecting, like a cancer patient who underwent the chemotherapy and WBC count was 100. And he had a fever spike and report was positive. So we had hardly 24 to 48 hours to take a decision. And within 24 hours, we have infused. And on 4th day, he was, actually the 2nd day he was discharged, but he stayed for 1 day more. And after 7 days, his count was 10,000 and he's doing well. So such cases definitely gives you the selection benefits. Now, regarding Rajesh, you are always putting the thread that the younger patients who are developing the serious category. I completely agree with the Dr. Om. Clinicians can easily judge which patient is going to worsen and which patient is going to. Now, for example, suppose what we are doing up till now in 1.5 years, if suppose somebody is coming in a fever OPD and he is a mild case, he is a home quarantine, a young patient. What we did, we managed with the conservative, with the paracetamol, where we are offer them any steroids or any other treatment. So why we are putting that uncertainty over those younger patients? He may deteriorate, because I have seen in past younger patients coming with the 40 score and NIV and he's deteriorating. So uncertainty, fear of worsening, confusion, I don't think that is a job of the experienced physician or any person. So I will look at it the same case. If suppose a younger patient comes to me, by my clinical judgment, he don't have any risk of deterioration, why I will thought about the monoclonal antibodies. On the other hand, like Prashant says, the EMI is 25, but hypertension is there, and there is some risk of the, in my mind is not settling down with sending him home with the paracetamol. I may consider the monoclonal antibody. So decision is with the clinician, decision with the assessment. We never take a decision on the basis of the just few seconds interaction or minutes. It is always on the clinical presentation, it is always on the experience, it is always on the what you see with your eyes and your colleagues, this thing. So I don't think there is any confusion about the healthy young patients, whether to offer monoclonal antibodies or not. But I would weightage on that, those patients who are really at the risk, we should go ahead and we should convince them and we should go ahead with the treatment. That's how we look at this scenario. I don't have any doubt, any uncertainty, any fear or any confusion regarding whom to offer and whom not to offer. And sometimes we may go wrong, but that is a part of that game. I cannot blame myself or the whole system for missing out the one or two younger individuals who later on deteriorated. Might be probably I failed in monitoring that patient in next 48 to 72 hours, or I just lost the communication with that patient. I will emphasis on that rather than not giving monoclonal antibodies to those individuals.
Okay. Subra, your turn, because you have used a lot and little bit of the tricks. If you want to give some key point, if you want to give, we will be very happy to hear from you.
Absolutely. We have crossed 110 doses so far. And a couple of things. I think, there has to be an SOP on this.
Subra, I'll stop 1 second. Can you just emphasize one thing? Do you monitor anything specific before you give IVIG? Monoclonal antibody cocktail, or just you give based on clinical criteria?
No, basically what we do is we have a single track system. All patients with COVID come to the ER. We don't allow them into our general OP, mainly because there is still risk of cross-contamination. That's inappropriate. So all COVID consultations, everything comes to the ER. When they come through the ER has a check sheet to look at whether they are criteria for the monoclonal antibody, and they are counseled immediately. The minute that happens, if they are candidates for that and they're willing to go for that, they're shifted to the COVID area. It's a 1-hour procedure. They come in, a line is started, consent is taken, a drug is infused over 20 minutes, monitored for 20 minutes. In the next 20 minutes, we then generate a discharge summary as a daycare admission. And that's why we don't do subcute. If you do subcute, you can't generate a daycare admission discharge summary, because if you generate a discharge summary, then getting reimbursement from the insurance may not be so difficult. And once we do that, then we have a system of follow-up with phone calls at day 1, day 3, day 7, and day 14, and sometimes even day 28. And we follow them up that way. That is for the preemptive regimen that we are talking about. For the therapeutic, obviously, the protocol is slightly different. If we do it protocol-based, there's less likely to be errors, and we see a lot less confusion. We put this in place even before we started doing this, and it's working absolutely seamlessly. We have not had a single conversion of mild to moderate COVID, even in extremely high-risk patients, into severe COVID in the patients that we've used so far. Everybody tells us that within 48 to 72 hours, there is significant benefit in the symptom relief. And yes, we've used it in all kinds of patients, including adolescents, to transplant, to advanced HIV, to cancer, to extremely elderly and things like that. So it's a very, the biggest toxicity to me is the wallet. But if the SOP is very clear and you have a standardized way of doing it, it's actually very easy. The problem is getting the patient in at the early time. Very often, unless you're a primary care provider, you're not going to get the patient. And that's one of the problems, because the IMA and people who are the ground level practitioners are not aware of this. So the referrals up are not coming up as quickly as possible. And I think that's where the mistake has been made. The gatekeepers are the primary care providers, and they have not been educated. And as a result, what's happening is there's a delay in patients coming for this. And many patients are asking, how come I didn't know about this option when they come in sick, which is unfortunate.
Okay, just one more question. So definitely, when you are treating somebody at large scale, you must be having some checklist to start, because it is done in emergency, and you must be having some checklist to follow up also. Quickly, can you summarize?
Absolutely. So we have a written checklist for this. So the first checklist is, does this person have a confirmed diagnosis of SARS-CoV? We only do the PCR. In my state, RAT is not allowed. But if they come from Andhra and they come with an RAT, we accept it. The second thing is duration of symptoms. We ask for the first symptom of onset, and it should be maximum of 7 days. 8 days actually gets excluded. Usually we prefer them coming within the first 3 to 5 days. That's 2. Third is no reason for hospitalization due to COVID. I'll give you an example. Somebody has a heart attack and gets admitted and has COVID for 2 days now. I will give them a monoclonal antibody. On the other hand, somebody is already developed hypoxia due to COVID. I will not give them a monoclonal antibody. So we need to be aware of all those nuances. Duration of symptoms attributable to COVID less than 7 days or less than equal to 7 days, and no hypoxia attributable to COVID. All of these points are important. If they satisfy all these checklists and consent is not a problem, then we go ahead and use it.
Perfect, perfect, very good. Dr. Joseph, your experience and input about what we have said.
Yeah, in fact, we were well after the peak of the second wave by the time we could lay our hands on this combination. In fact, we've been using it after the worst was over for us. We have used in about 12 patients so far. And from the experience that we've gathered so far, it's too small a number to make any definitive comments, but none of these patients required hospitalization, which is okay, but obviously you cannot say for sure with this very small sample size. The other thing that I wanted to mention was that we were talking about being very choosy about the way we use monoclonal antibodies at this point of time. Yes, of course, given the evidence we have, and of course, we need to prioritize who gets it and who does not get it in a situation where availability is a problem, cost is a problem. But the situation may change in the future, and we may have more access to this, and the cost may come down, and we may, in fact, switch to a situation wherein we offer it to more people and perhaps fitter people than whom we are using it on currently. That's just my feeling.
Thank you, sir. Dr. Deepak, very quickly, a summary of whatever you have experienced about the monoclonal and your thought about what we have discussed.
I am an odd man out here. Yeah, I am an odd man out here. I don't have got any real-time experience. Whatever I can share is either by listening to you all or the theoretical knowledge. So practically, I have not used in any patient. That is my submission. And as far as the theoretical part has already been told by everybody, and Dr. Subra has given his protocol. So I don't have anything new to add it. Thank you.
Before I go to the Prashant, Dr. Om and Dr. Subra, one more question. Did you find any unusual infection, unusual complication, something like particularly infection point? Because Dr. Om was pointing out, after giving monoclonal antibody, any opportunistic infection, any bacterial infection or something like that?
Subra, you want to answer first?
Yeah, no, actually, no. The only issue is, I think we did have one patient who had a prophylaxis secondary to the highlight insert, but short of that, actually nothing much. Patients actually did very well with it. I have not seen even hypersensitivity responses to that, so not really.
Yeah, so I have not seen hypersensitivity responses either, but I have seen in some ICUs, besides the one that I was talking about, where I've been asked to opine on the use of monoclonal antibodies in critically ill patients or moderately ill patients, I have seen that there is a predilection of the fastidious gram-negative organisms, and those which we'll find it very difficult to get rid of, like the Burkholderia species, the Cepaceas, which once you've got that into a blood culture, it's very difficult to get rid of that. So the fastidious gram-negative organisms, including some of the Hatchett group of organisms, I've seen them, yes. I don't know whether that's a complication of the total, suppression. There is a lot of renewed interest in the HLA1 and the association with bad outcomes with COVID. Though those papers, if you'd like, I will share it with the Rajesh, and you could share it with the rest of the panel. There is renewed interest in the immune part, that you've got to be careful not to wipe out the protective part of the immune system in your desire to give a monoclonal antibody. So that is something that we will see more and more of. We will learn more and more of as time goes on. But other than that, no, if you're careful about dosage and timings, most people do very well with monoclonal antibodies.
Shant.
I'm sorry.
Thank you, Dr. Rajesh. I think before I go to my experience, that is much more of a central experience. I want to add one more important point here. We know that neutralizing action of these monoclonal antibodies, which is basically through RBD and NTD terminal, but there is another action which is supposed to be the reason of antibody-dependent enhancement, ADC, which is a very big issue, which was initially proposed when monoclonal antibodies came up. That is through FC-mediated, activation of effector cells and complement pathway. And that is still a very big issue which is being proposed, especially in the critically ill patients, where we are not sure whether the antibody response has been generated enough, and you are using a higher dose. And in these patients where already an inflammation pathway has already been set up, giving antibodies in those patients may be an ADC. And that is also one of the concerns when you consider monoclonal antibodies after vaccination. So ADC is something which is still under a lot of research, though there is no good evidence on that. But yes, it's a hot debate, rather, I should say. Talking about our own experience, we are privileged.
It is one of the sub point underlined to be discussed.
Yes, to be discussed.
Yeah.
Regarding
I'll come, Dr. Kirino, I'll come to you.
We were privileged. Yeah, we were, sorry, I will just take another 2 minutes. So regarding our experience, we were privileged enough that the cost is taken care by the government. We have a central command center which gives Strobimax, a 500 milligram. So far, that center has given 13,000 patients as of 3rd August. And that, recently they shared experiences with the healthcare professionals. The response rate was 97% reduction of the mortality and 99% reduction in requirement on ICU. So that's a very big number, and probably they are going to publish that data too with the Strobimax, because that's I think largest experience they have, 13,000 patients. For us, we cannot prescribe because it's cost given by the government and taken over by the government. So we only refer the patient to that center. So whatever we hear is directly from the patient and from the consolidated data which comes from the central command center.
Dr. Kirino, your quick comment, and there are 2 important questions I will take after that. Dr. Kirino, your quick comment.
Yes, I would like to share our experience that is with many patients about monoclonal therapy, and which is our golden standard. Our golden standard is very clear, is that the patients must be treated with anti-clonal therapy with immediately after the amplification test. That means before any manifestation of the disease. I read that we need to wait the X-ray, the other examination. No. When this result is positive, the golden standard say you must start the treatment. And so it's very difficult to discuss about infection disease and intensive care therapy, because in my intensive care therapy, I am not allowed to give this kind of therapy. And when I request monoclonal therapy, I must justify for experimental. And our results are very clear, and you have that if you do this therapy too late, there is no benefit. And I saw that some people give 3,000 milligrams of these drugs, and this is crazy, because the right dosage is more 1,400 for one combination, and for the other is 700 milligrams. So it's a silly thing. I don't, from a scientific point of view, if you go to the literature, I don't find any support for this strategy. Okay, I'm sorry.
Okay, so there was one question.
Opinion,
the
data that we have.
There was one question. I think anybody can answer. When somebody can take vaccine if you have taken monoclonal antibody? After 90 days, it is up to 90 days. As I have already discussed the case also, that within till 90 days you cannot take the vaccine. You have taken monoclonal antibody since again. So with this, just if I have to quickly summarize about the monoclonal antibody cocktail, the 2 drugs are given in combination to prevent and to take care of the emerging resistance, emerging variant strain. It has to be given early, particularly post-exposure prophylaxis is early, precisely in high-risk patient, not more than 7 days. If you are between 7 to 10 days, there are a lot of gray areas. There are a checklist, no oxygen requirement, no lung involvement, and still, if you think patient needs it. Patients who are having high risk of worsening, they are the first category of patient who needs. Second category of patient who are poor responder to vaccine, who has not made up the antibody. And third category of the patient, you have taken first dose of vaccine, antibody buildup is not there. And the other group of patients who are poor responder, who get repeated exposure, who have the risk of repeated exposure, they form a special category where they may need a second dose after 4 weeks, just to take care of the to reduce to avoid the further reinfection with this thing. We have to just take care of the anaphylactic reaction after, because it has to be given IV. It's a monoclonal antibody, though it's a human monoclonal antibody, but it's still up to hours. Preferably, first 2 hours are important to monitor. After that, under observation, as a daycare, as Subra said, one can go home. You should have very stringent checklist to before you give this medicine, and particularly if you are PCR positive, you do not have any organ involvement, you do not have, particularly do not have oxygen requirement. You should have a high risk to for worsening of this COVID infection. So you should have a strict checklist. The dose is 600 milligrams, 600 milligrams, both the monoclonal antibody, preferably IV has to be given. Monitor for side effect. So far, whatever data we have, it is saying that even Delta plus variant also can be taken care of this monoclonal antibody cocktail. The precision, which is their timing, and also important whom you will not give. So far, we do not have a data to give in severe patient who needs oxygen, who are on ventilator, who are on any kind of oxygen support. A young patient who are not having any risk except fever, all parameters normal, no risk of worsening. These are the group of patients where you can observe if you don't give in monoclonal antibody. Still, we are learning about the molecule. A lot of new thought can come, and probably after some time with more experience, we'll have more thought. Thank you all. Thank you, Dr. Kuino, for excellent narration. Dr. Om, Prashant, Dr. Joshar, Subra. Nice to hear from you, Dr. Kapil, and Deepak sir. Thank you, everybody, and have a wonderful evening and good night.
Great to be here. Thank you very much.
Thank you to everyone.